Hi, my name is Luis Macedo. I'm a professor of implant dentistry at São Leopoldo Mandique Dental School here in Brazil. And first, I would like to thank Geistlich to be invited to be part of this new project and to show you a new concept in bone augmentation called barbell technique. And I'm going to start to discuss with you two different clinical situations. As you can see on the left side, you have a horizontal bony defect, but on the right side, you have not just a horizontal bony defect, but you have a vertical bony defect too. And this is a more critical and challenging situation in our clinical practice. And it's important to understand that this is a physiological process. And a paper published in 2011, a consensus report by Osteology Foundation, showed that within 6 months after tooth extraction, you can achieve a horizontal bone resorption of almost 4 millimeters. But you can also achieve a vertical bone resorption of almost 1.3 millimeters. And we use it to say that this bone resorption occurs based on the presence of a thin buccal bony wall. But as you can see in another different clinical situations, despite the fact that the buccal bone resorption is more pronounced and is more evident, the palatal bone resorption could not be neglected because it would interfere in the prosthetic ideal position of our implants. Pellegrini and colleagues in 2010 published a human study in clinical oral implant research and showed almost 35% of resorption after 6 months. But take a look at the numbers. I'm talking about the 2.4 millimeters of total resorption. And of these 2.4 millimeters, 0.7 millimeters occurred on the palatal side. And different techniques have been published in the literature to bone augmentation. And one of them is tent-pole technique, first published by Hampton and Fugazotto in 1994 in implant dentistry, and 16 years later by Lee and colleagues. And the technique is based on placement of a titanium screw partially inserted into the defect to support the soft tissue against compression that could cause displacement of the bony particles. As you can see in this clinical situation, you have on the left side of the slide the small defect in the anterior maxilla. We partially installed a titanium screw. You put the biomaterial. This is a bio-gide small granulus, a resorbable collagen membrane as the GBR principles. And you can see on the right side of the slide, after 6 months, the good results in bone augmentation at the good soft tissue counter. But it's important to say that this is a small defect because in large defects, another paper published this year by a Chinese group showed that in comparison to bony block technique, tent-pole technique failed to promote the ideal support in large defects. And the soft tissue compression caused the displacement of the bony particles and hence the reduction of the bone volume. And we can hypothesize that the problem is that the screws that we have been used for this technique were not designed specifically for this technique. And in this situation, you should use a complementary material as a titanium pins or a titanium screws, not just to stabilize the membrane or to fix the membrane, but to stabilize the bony particles of the biomaterial in the defect area. And you can use a titanium reinforced PTFA membranes or a titanium mesh to promote mechanical support. But it's important to understand that both biomaterials are hydrophobic materials, so you should remove on a second surgical procedure. And based on these problems, we started to think in a new concept of bone augmentation. And you thought that if you have just one screw transfixed through the bony defect and another material, other complementary material to support the soft tissue against compression, we could achieve bone augmentation. And this concept and this technique is called barbell technique because of the similarity with a barbell a long barbell that we can use to raise the mass, to raise the muscles in a balanced way in the gym. Okay, so the concept in bone augmentation is the same. What we need is to augment the bone in a balanced way. And this concept and technique was published as a technical note in Journal of Autoimplantology in April of this year. And the components of the barbell device are a 1.5 millimeters titanium screw and 2 PIC capsule. A capsule produced using polyether ether ketone, that is a tooth-colored polymer that has been used in orthopedics and prosthodontics for many years, and a lot of papers in the literature show it, the biocompatibility of this material, the high biocompatibility of this material. And an interesting paper published in 2019 by a Brazilian group in iGeom showed that we can find more adhesion, more proliferation of gingival fibroblasts in contact with the PIC surface in comparison to titanium or zirconia. And let's discuss a first clinical situation of bony atrophy in posterior maxilla is a Hackett 3 defect. This classification was published by our team in 2018 in Brazilian Auto Research and is based on the presence of cancellous bone or the absence of cancellous bone. And the presence or not of cancellous bone could predict the material for bone augmentation and the surgical technique that we should use to improve our results. As you can see in a Hackett 3 defect, you have the presence of cancellous bone, so you can use just an osteoconductive biomaterial. As you can see in the CT scan, you have the presence of cancellous bone, and in the clinical aspect, you have the buccal bone resorption and the palatal bone resorption too. So let's define our surgical technique using just an osteoconductive biomaterial. And if you think the ideal prosthetic position of our implants, it's obvious that we should perform bone augmentation on the buccal side, but we should perform bone augmentation on the palatal side too. And we start the procedure preparing the recipient bed using a 1.1 millimeter drill. We used a 1.5 10 millimeter barbell screw transfixed through the bone. We prepare and installed the PIC capsules on both sides of the screw. We cut, prepare, and we adapted the collagen resorbable membrane and put the biomaterial, the synergenic biomaterial. And here we have the summary of a clinical case. As we can see on the left side, you have the baseline Hackett 3 defect. On the center of the slide, you can see the technique for bone augmentation, and 6 months later, we have the good results in bidirectional bone augmentation. But let's take a look and discuss another clinical situation, a more critical situation, because we have a bony atrophy in the anterior maxilla is a Hackett 4 defect. A Hackett 4 defect, we have absence of cancellous bone, so is a more critical defect. As you can see in the clinical aspect at the baseline, you have resorption on the buccal side, but we have a huge resorption on the palatal side too. And take a look at the CT scan, as you can see that we don't have presence of cancellous bone. So it's a more critical defect as we classify as Hackett 4 based on our classification. And take a look at the defect on the clinical aspect. We have a huge defect on the buccal side, but we have a huge defect too on the palatal side. And again, if you think the ideal prosthetic position of our implants, it's obvious that we should augment the bone on the buccal side and on the palatal side too. I mean, in a bidirectional manner. We started again preparing the recipient bed using 1.1 millimeter drill. And in this case, because we are performing a surgery in a large defect, we used 3 barbell screw, 1.5 10 millimeter barbell screw transfixed through the bone. It's important to discuss that the numbers and the position of the barbell screw depends on how much bone you need to gain. Okay, and in this situation, of course, we install the screw in a more buccal position because we should augment the bone in a more buccal position in comparison to the palatal position. Here you can see the two P capsules adapted to both sides of the screw. We cut and adapt our collagen resorbable membrane. This is a bio-gide membrane, and we prefer to use a collagen membrane because collagen membrane has demonstrated in animal and human studies to promote the mesenchymal stem cells attachment and growth factors and osteogenic differentiation better in comparison to hydrophobic membranes, barriers. And here you can see the use of a biomaterial, 50% of xenogenic and a 50% of autogenous bone particle because it's a HEG4 defect. And this mixture was published in a systematic review by Hannah Luding in 2017, showing good results. And in another paper published in 2019 by Silva Meloni, in a 3-year loading perspective clinical study showed excellent results with this mixture. And here again we can see the collagen membrane covering all the graft, and take a look that we don't have to use titanium screws to fix the membrane or titanium pins to fix the membrane and to stabilize the bony particles. And here you have the summary of the clinical case. In the upper part of the slide, you can see the CT scan at the baseline and the clinical aspect at the baseline. And after 7 months, you have the CT scan showing good results in bone augmentation. And we have the clinical aspect after 7 months showing a good volume and a good results. The clinical aspect, as you can see here, the clinical aspect during the first surgical procedure with a HEG4 defect, and the clinical aspect at the second surgical procedure after 7 months showed the good results in bidirectional bone augmentation. In summary, we can discuss some advantages of the BARBELL technique. First of all, we can use a particle bone graft. A particle bone graft is better for bone regeneration because it will promote fast vascularization and cells in growth, and it's easier to adapt it to regular recipient bed. We can use a hydrophilic collagen membrane because allows vascularization and nutrition for the regenerative process. A titanium screw and a PEEK capsules. We don't need complementary material to promote mechanical support against soft tissue compression because a titanium screw and 2 PEEK capsules are enough to do it. And the versatility of the technique because we can use it to promote horizontal bone augmentation in a unidirectional manner, or a horizontal bone augmentation in a bidirectional manner, and a vertical bone augmentation too. And depends on the kind of defect you want to perform surgery, you can select the ideal screw to adapt it to the bony defect. And we have available a 1.5 millimeters to 6 millimeter, 1.5 80 millimeters or 10 millimeters screw, depends on the kind of the surgical procedure you want to achieve bone augmentation. So I hope you enjoy this new technique and this new concept in bone augmentation. And if you have any questions, feel free to contact me by email in this address. And thanks Geistlich one more time to invited me to be part of this project. And thank you for your attention.